Thank you, Nati, for your kind introduction. It's a privilege to be invited here at this morning session of diabetic retinopathy management. It's a global epidemic, and question is, are we ready to battle this epidemic? What I'm going to cover now is anti-VEGF drugs, which are the first line of treatment in centers involving diabetic macular edema. But my topic will be covering not only DME, but also PDR, and also the number 3 is the progression of diabetic retinopathy. These are my disclosure for conflict of interest, and this is my institution, University of New Mexico School of Medicine, where I've been working for the last 20 years. So we all know that VEGF is upregulated in diabetic macular edema. But again, very important that, if you look at the level of VEGF, compared to the control, the DME patients definitely has a much higher level, and that has been shown by Funatsu's group. And also, he has found out that VEGF level in the vitreous goes higher, much higher in the extensive DME patients than with the minimal DME. But please note that this vasopermeability factor, VEGF, is all over. You see, in this group of DME patients, some of them are very high levels, some of them are very low levels of VEGF, although the average is much higher. What it tells us that DME is a heterogeneous disease, so not all of the patients DME are getting benefits, the same amount of benefit as others. Maybe only 30 to 40% patients are very good responders. There are 30% patients are poor responders, and in between there are intermediate responders. So there are other factors beyond VEGF which are also playing a role in diabetic retinopathy and at least in diabetic macular edema. So VEGF has been targeted by different pathways, different molecules, anti-VEGF molecules like Avastin and Lucentis, originally the Macugen molecule, and later on the aflibercept of the VEGF trap molecule. And there are other approaches like siRNA, and then this is a clinical trial going on with the squalane, which is actually a topical preparation that targets multiple growth factors, just not VEGF only. VEGF, PDGF, basic fibroblast growth factor. This is in actually wet ARMD clinical trial, but this will be actually tested in the DME patients very soon in the next few months. So we all know that this is a very classic picture where I'm showing the good responder, where you can see the baseline DME in these both eyes, in the right eye and the left eye, and just with one injection of anti-VEGF drug, you can see a significant improvement. But this is not always the case. This is maybe a 30% patients we see the improvement. So we know that anti-VEGF drugs work, and they result in substantial rapid visual improvement in DME patients. And there have been several clinical trials have shown this, the beneficial effects of anti-VEGF drugs. RIDE and RISE study, which looked at the Ranibizumab dose of 0.3 and 0.5 milligram. The RESOLVE study, again, the same two doses, comparing with the sham. Protocol I, the DRCR studies, we looked at the 0.5 milligram and then prompt laser and the delayed laser compared with the laser, and there was a fourth group of triamcinolone. RESTORE study comparing between Ranibizumab and combination of Ranibizumab laser and laser. VIVID VISTA with the aflibercept, and Protocol T, which is actually finished 2 years, and I'm going to share the results of Protocol T 2-year results today. The result just came out last night. It was because of the confidentiality of the results of the 2-year results. I was told not to present until it is official. Actually, last night, just only 12 hours ago, the results have been online, and now I can share the results with you. So all of these trials with the anti-VEGF drugs, you can see, starting from BOLD study, which dealt with the bevacizumab and laser, about 8, 10, 11 letters of improvement, average. Looking at the READ2 study, I happen to be involved with the READ2, RIDE, RISE, and the DRCR studies, and I will share some of the results today. But all of these clinical trials with the anti-VEGF drugs showed at least 8 to 11 letters of improvement after 2 years to 5 years. If you compare all the trials together, These yellow and the blue lines are actually the DRCR protocol, about 8 letters of improvement. And this is the longest one, is the 5-year results, the DRCR. These are the RIDE studies. It's about 3 years. You can see there is definitely in those studies, the improvement is almost like a 15 letters improvement. So there is a variability, but the average is plus 8 to 11 letters of improvement. So I'm going to now share the protocol T results, which compared the 3 anti-VEGF drugs. The reason is that one of the drugs, bevacizumab, is the least expensive, and aflibercept and the ranibizumab is much more expensive. And this is also for here. And so question was, can you use bevacizumab for DME patients? And this study did a head-to-head comparison between these 3 different anti-VEGF drugs. So I'm going to show first the year 1 results, which was published last year, and then I have got the update on the year 2 results. So this study was randomly assigned DME patients in the aflibercept group, 2 milligram, bevacizumab, 1.25 milligram, and the ranibizumab 0.3 milligram, and they are followed for 1 year. So here you can see the mean change in the visual acuity when you take the whole cohort together, all the patients, full cohort. So you can see the green line is the aflibercept, the Eylea, is about 13 letters improvement. This is about 1 year. This is ranibizumab, and then this is a bevacizumab plus 10. So it is between 13 and 10 letters, very similar. Very similar when you take the whole cohort together. They're all equally effective, causing an improvement of plus 10 to 13 letters. But if you do a sub-analysis, and when you compare the visual acuity with the baseline is very good, that means 2030 to 2040 at the baseline, you see no difference at all between the 3 different drugs. There is a plus 8 letters of improvement in this group of patients. Again, this group of patients is about 50% of the cohort. So what happens when the vision is poor? The baseline vision is worse. It starts from 20/50 or worse, which is actually the other 50% of the cohort. You see a big difference between these 3 drugs. Actually, the aflibercept has a plus 19 letters compared to the 14 letters in the ranibizumab, and the white is bevacizumab. So between ranibizumab and bevacizumab, there is not much difference, but there is definitely almost a 1-line improvement, more improvement in vision in the aflibercept group, and that's why aflibercept happened to be the leading drug in DME treatment when the initial visual acuity is 20/50 or worse. If you look at the subgroup analysis, this is the summary again, 2030 to 2040. No difference between the 3 drugs. In this group of patients, any of these drugs equally effective. But in 2050 or worse, you can see there is a big gap here. The Eylea or the aflibercept is definitely a 1-line better. So what happens to the OCT thickness? If you look at the OCT thickness again, you are seeing about thickness changes is significantly in aflibercept group, 169 micron, compared to the bevacizumab group, 101 micron, and ranibizumab is about 147 in between. So now I'm going to share with you the protocol T result just came out last night. So at the year 2 years, what you are seeing here, very interesting. If you take the overall cohort, there's not much different. They're very similar. This is the 10 is Avastin, 12.8 is the Eylea, 12.3 is the Lucentis. They're very similar. Look at the now. We talked about the worst vision acuity. This is a B. That means 20/50 or worse baseline vision. You can see 18 letters improvement in the Eylea group. Look at this line here. This is the 16 letters. This is the Lucentis group, and the Avastin is plus 13. So basically what happened, the difference that we saw in the year 1 results between the Eylea and the Lucentis is no more there. They are equally effective at the end of 2 years results. That's what is the most significant finding of the DRCR protocol T. You can see here is almost very similar. Still there is a gap between Eylea and Avastin, about 5 letters still there, even at the end of 2 years. But the gap between the Eylea and the Lucentis is not statistically significant. If you look at again the same thing, that means the basal visual acuity is 20/40 or better. On the right hand side, the C, there is no difference between the 3 drugs. So we all know that as in year 1, there is no difference between the 3 drugs when the visual acuity is good at the baseline level, but when the visual acuity is worse, 20/50, still Eylea is better, but it is better than Avastin. The Lucentis is very similar to Eylea. So to summarize the DRCR protocol T results, 2-year results, all 3 anti-VEGF agents are effective treatments for DME, causing vision impairment. When initial visual acuity is mild, that is 20/40 or better, the average, on average, there is little difference in visual acuity at 1 year and 2 years, the same results. But at worst level of visual acuity, we can see Eylea is still more effective at improving vision than Avastin at 1 and 2 years. And Eylea or aflibercept improved the vision more at 1 year than the ranibizumab. However, the difference diminished and is no longer significantly different at 2 years. I think Genentech will be very happy with the results. So again, as I mentioned, this is from the RISE study, the results of visual improvement. You can see in the RIDE and RISE study, if you compare between the sham injection and the 0.3 and 0.5 milligram injections, there's about 33 to 45% have this vision improvement of 15 letters. That means 3 lines improvement. These are the good responders. So not 100% of the patients having this response. There are about 1/3 of the patients showing very good improvement. Other patients were not seeing the same kind of response. And this is true for Vivid Vista study with the aflibercept and also for the DRCRY. So 1/3 of the patients are doing very well with the DME, with the anti-VEGF treatments. Again, another third of the patients have a residual macular edema in spite of the monthly injections. The other thing that came out, in addition to the improvement of the DME, the anti-VEGF drugs were found to slow down the progression and reverse the diabetic retinopathy features. It was shown in the RIDE study. This is the figure on the left. You can see this is with all the hemorrhages and cottonwool spots. This is the baseline photograph, and this is the same patient after 3 years of protocol treatment with the ranibizumab monthly injections. You can see almost disappearance of all the hemorrhages and cotton, much less severe retinopathy. So this was published by Michael Leap on behalf of the RIDE study in ophthalmology. And the same thing was found by the Vivid Vista study. There is also 2-step improvement in the diabetic retinopathy severity scale with the treatment with the Eylea. So not only it reduces the diabetic macular edema, but also helps in slowing down the progression of diabetic retinopathy and, in fact, reversing the diabetic retinopathy feature. So these 2 drugs, actually both aflibercept, Eylea, and Lucentis, are now approved by the FDA for treatment of diabetic retinopathy in presence of DME. So if somebody has a DME, there is another second indication of these 2 drugs is the treatment of diabetic retinopathy, the disease itself, for the diabetic retinopathy features. Now I'm going to talk about another study, DRCR protocol ACE, that came out recently that compared between the prompt PRP laser versus the ranibizumab and PRP combination, and this is called the protocol ACE. So the primary question was, is visual acuity using ranibizumab for PDR is not worse than treatment with PRP at 2 years? And the secondary question was, are there potential benefits of using ranibizumab injection on vision throughout the follow-up, peripheral vision, macular edema, and incidence of vitrectomy? So the patients were randomized between the 2 groups. the Ranibizumab group and the PRP group, and you can see almost very similar number of patients in both groups, and they have followed for 2 years. Actually, the study is still going on. These patients will be followed for 5 years. So what we are seeing here, the PRP laser group, you can see as expected, there is not much visual acuity improvement. Is only plus 0.2. So there is no improvement in visual acuity in the PRP group. But what we are seeing in the dotted yellow line, which is the Lucentis group, there is an increase. There's a gap between this almost 1 line improvement in the score of visual acuity score. But by 2 years, you can see it is kind of approaching the PRP laser same. So this is called under the curve analysis, where they are talking about there is definitely a benefit of visual acuity improvement during this 1 year period here, but the efficacy in visual acuity improvement goes down with the time. So it happens that in terms of the visual acuity, the ranibizumab injection is not inferior to the PRP laser. It is important that a subgroup of these patients with DME, with the baseline DME, that means the PDR patients who had DME to start with, which is about 25%, had a very significant visual acuity improvement. That is expected because these patients have DME. So the DME is corrected as we do the injection. So injection with the ranibizumab has about 8 letters improvement compared to the PRP laser group. Again, as expected, the peripheral visual field measurement showed that definitely there is in the PRP group, there is a big visual field loss in the periphery as compared to the ranibizumab group. And that's the main reason everybody is leaning more towards the ranibizumab injections, because you don't have the side effect of the visual field constriction in the ranibizumab group. So the DRCR protocol A's conclusions are, number one, we know that PRP is an effective treatment, has been for the last 4 decades, still remains effective treatment. And again, ranibizumab injection for PDR is at least as good as, or you call it non-inferior to, PRP laser for visual acuity at 2 years level. Ranibizumab is an effective treatment alternative to PRP for PDR, and no substantial safety concern for at least 2 years, and maybe the preferred initial treatment for patients who have PDR and DME at the baseline. And again, as I mentioned, these studies going to be followed for another 3 years. So again, the question is, how safe are the anti-VEGF drugs? Different clinical studies, starting from RIDE, READ, and all these, DRCR, they did not find any significant increased side effects of the anti-VEGF drugs over the period of 2 to 5 years. A recent Cochrane meta-analysis in the DME patients has shown there is no excessive risk for systemic adverse events or arterial thromboembolic events and overall mortality. But there's another study just came out in JAMA Ophthalmology by Bob Avery from Santa Barbara. They showed that those patients in the protocol received monthly injections religiously continuously for 2 years. Some of the protocol demands that you do the monthly injections for 2 years. So that group found out that if you do that, and there was an increased risk of cerebrovascular accident and vascular death. Again, in real life, people are all injecting maybe 9 to 10 injections in the first year, and the number of injections goes down to 3 to 4 in the second year. So there is a big disconnect between the clinical trial protocol and the real life practice. So, but in this meta-analysis, it has been shown that you cannot inject anti-VEGF drugs monthly continuously for 2 years. You are going to see some bad effects. So what are the challenges? Monthly injections are treatment burdens, as you know, not only for the patient, for the doctors and their families, the patient's families. Again, as I mentioned, only 30 to 40% of the DME patients show good results. That means 2 line of mode visual acuity improvement. Again, in spite of all these monthly injection treatments, still a 1/3 of the DME patients have been shown to have residual persistent fluid in spite of all these injections. And it appears that it may be, again, as I mentioned earlier, DME is a heterogeneous disease, and there is a lot of other cytokines and chemokines play a big role in the pathophysiology of DME. Again, we all know that cost effectiveness of these 3 different drugs and which one to use. Again, in good visual acuity baseline, we don't have any issue because you can start with any of the drugs. But for poor baseline vision, as the protocol T has shown, that Eylea definitely is still the best drug. But again, with the publication of 2-year results, we can see Ranibizumab actually also very similar to aflibercept. And finally, there are several drug companies, including Genentech, are working on sustained release drug delivery system to deliver anti-VEGF drug into the eye for a longer period of time. And there's a trial going on called ladder trial in wet AMD patients. Hopefully that will answer this question. And again, there are many other clinical trials are going on targeting the other molecules which are important in DME. Thank you.